Hello and welcome to Yodo. I'm Dr. Sarah Bohn. Today I'm going to practice an education piece that I'm going to give to some mental health professionals. This is November, it's Hospice and Palliative Medicine Month, and we're celebrating the specialty of hospice and palliative medicine and our partners in mental health. Hospice and palliative medicine are disciplines that address the patients that are at the highest risk, the most frail of our patient population. We want to affirm life in hospice medicine, and we want to regard death and dying as a natural process. The disciplines providing care to patients and support to their families include physicians, nurse practitioners, RNs, LPNs, chaplains, aides, and of course mental health professionals. The LCSW, psychology, psychiatry, as well as we do get help from pharmacy, we get help from the nutritionist, we have bereavement support, which is also mental health, and we have representatives from multiple therapy specialists, OT, PT, speech therapy, pet massage therapy, art therapy. There are many different therapists that provide help, but today I really want to address the mental health professionals that are assisting us with meeting the patient's needs and supporting their loved ones. It takes many of these disciplines because we want to address body, spirit, as well as mind, assisting that person and their loved ones through a very difficult part of their life journey where everything is changing. Function of the patient, relationships of everyone involved, and the management of those symptoms becomes paramount of importance for that person. Mental health support is crucial for these people, addressing the aspects of the patient's life and their concerns, the different roles, independence, their lifelong journey. Palliative and hospice medicine is a team because we're supporting so many different things with this person, and that person is the center of that team. The patient's needs and their goals of care give the direction to the members of the team supporting the person and their loved ones. The importance of mental health support in addressing these changes, and in particular the losses, is of paramount importance. The losses may be the changes in their role, the loss of their independence, the loss of their life, and how the things of their life are altering over time, and it can seem like it's occurring on a daily basis for some people. Support is needed for anticipatory grief as well, because they see those changes many times and they can realize what is at stake and what's happening. They and their family are needing that extra help. So palliative medicine focuses on symptom management of those patients with serious illness, and sometimes when a person has a serious illness, they can really get caught up in the day-to-day, week-to-week activities of taking care of that serious illness, whether it's taking medications on time or going for a new test or finding a new specialist or a follow-up appointment or another imaging is needed, but they can really get caught and tied up in that, and they can kind of tend to lose track of how changes are occurring. When patients reach a point where curative intent is not available and it appears that life expectancy is severely limited to 6 months or less, that's when hospice medicine can step in to provide even more support than what they've been getting through the palliative support. The hospice benefit provides for that additional support and has all of those team members, many of which are required by federal regulation, by Medicare, CMS, private insurances, and even at the VA, those multiple disciplines are required. For veterans, for children, and for some insurances, they are eligible for something called concurrent care. So it's the hospice benefit plus disease-directed care that they're also eligible for. The topics that are covered have to do with the disease state and stage, has to do with the prognosis and trajectory, as well as the advanced directives. And we do have various videos on this channel regarding all of those things, and in particular, the life-sustaining treatment choices that the patient has. Discussing those with the patient before crisis occurs is of key importance. We don't want patients or families to make decisions out of fear, and then they've not really considered what's happening until that 11th hour, and now they're afraid and they feel they need time to consider and to reflect. So with a healthcare surrogate and loss of capacity occurring, that's when you're going to need that advance directive to be in place. If it's not in place and there's no clear surrogate, then we really have to have legal documentation to support who's making those decisions. And so addressing that early with the patient as to who do you trust the most to make the decision you would want. Don't relinquish your decision and put burden on your family. They're already burdened by the thought of losing you. You can frame what end of life looks like for you. We realize that people want more time, and sometimes there are occasions in everyone's life that that's the one thing we can't provide is more time. So the healthcare surrogate, when the patient loses capacity, is the one who tells us what that person would want. And we require 4 things for that determination of capacity: understanding, appreciation, reasoning, and communication. And so we need those 4 things to be able to be demonstrated by the patient for their ability to make those complex medical decisions. And a patient may have the ability to make decisions regarding one thing, such as receiving antibiotics, but they may not have the full capacity needed for another complex medical decision making, such as receiving surgery, because the surgery may have risks that are involved and limited benefits, and they're searching for that glimmer of hope and not really understanding how much is at stake and how much is at risk. So we need to ensure understanding, appreciation of their situation, the reasoning for the choices that they're going to choose, and then their ability to communicate that. And the communication isn't just like being able to verbalize something. It might be with thumb signals, finger signals, it might be writing things out, it might be with eye blinks. So as long as we're able to discern that they're able to understand, appreciate, and reason that, the communication, we can be pretty flexible with that. The healthcare surrogate is a big responsibility. It is a little bit of a burden, but it's a huge honor. So as long as they regard that burden, that their burden is to know what that person would want and to be that individual person's voice to tell us, if they were able to speak now, this is what they would want. That's a tremendous demonstration of selfless love. So the healthcare responsibility is a big one. It is a burden, but it's also a position of honor. The LSTs, or life-sustaining treatment choices, include things like CPR, ventilator treatments, artificial nutrition, dialysis, receiving of blood or blood products. And the person, the patient or the surrogate, needs to be able to understand the beliefs about those particular things. For some patients, fluids, receiving artificial hydration, can also be a life-sustaining treatment. Now, if it's fluids for comfort because someone is dehydrated, their mouth is really dry, we can use nebulizer treatments of saline to try to help, moisten their mucosa or help keep their nose or mouth moist. We can give limited amounts of fluid by IV. But if it's at the end of life, we don't want to overdo artificial hydration because the person can fill up with fluids and a gurgling sound can be made. So we want to ensure we understand how that person wants to be cared for as end of life approaches. And some patients want to be at home. Some patients don't want to go back to the hospital one more time because what's broken can't be fixed. And they prefer to have a natural passing, and they prefer that passing to be in their home or home-like environment with their loved ones there to support them. So sometimes we even talk about, do they want to have transfers to another location as end of life occurs? And some patients don't. They want to remain in their own home. In the state of Florida, we have a yellow piece of paper called a community do not resuscitate form, and that is required in the state of Florida to ensure that that patient is able to have that request respected. Sometimes families don't have hospice assisting them, and even if they do, they might have someone get anxious as end of life approaches, and they will call 911. With that yellow form, it ensures that the emergency medical system, the EMS services, knows what they are supposed to do and how they're supposed to respond. And when they come on site, if the patient is expired, it tells them that this was an anticipated end of life and that the patient knew, as well as their attending physician, and that death at home in the family setting is what was requested, and they can assist that family from that point. If hospice is involved, then they will certainly call hospice at that point. So the goals of palliative and hospice medicine is to identify and manage those symptoms. It's to decrease the disease burden to the patient as well as their loved ones and caregivers. It's to provide honest information in a compassionate and empathetic manner, in an ongoing longitudinal way, as well as we emphasize that comfort. Hospice specifically is to provide and prioritize comfort and quality over quantity of life. So it gives that extra layer of support for patients as their disease advances and they decline over time. So it gives them that extra quality of life that they want when their length of life is anticipated to be very short. We want to satisfy their desires best we can for an active living. As long as they're able to continue to live, we want them to be as active as they possibly can and limit the burden of symptoms. So hospice is neither to hasten death, but it's not to prolong that dying process either. We want to provide care when cure is no longer possible. Empathy versus sympathy. I think if you guys have not seen the Brené Brown, it's like a short 3-4 minute video on sympathy versus empathy. I mean, I really enjoy and I love that video every time I watch it. But it really stresses what the difference between empathy and sympathy are. So if you've not watched that, you should look up Brené Brown, her video, and I can actually link it in the description box below. We want to use appropriate terms to inquire about the patient and their loved ones and their ability to understand the information that we have given them and we've provided regarding their disease and disease process, as well as that prognosis and trajectory. We want to learn about what's acceptable for them for that quality of life that they would still be happy with. Because some people feel like if you're going to put me on a machine and I'm going to be required to stay in a hospital, that's not a good quality of life and I would not want that. And if you're going to tell me the chances more likely than not, that's not acceptable either. If you're going to tell me that I've got a 70% chance of this or a 30% chance of that, that helps them understand what they're up against so that they can tell us about that acceptable quality of life. It's almost every day that when we talk about life-sustaining treatments, patients will say, well, it would depend. And that's exactly what we want to know. We want to know what it would depend upon. We want to learn about their belief system. We want to understand what their goals are. And we want to know when life-sustaining treatments are appropriate and when they're not. Some people of a religious belief may not want some life-sustaining treatments, and other people may, because of their belief in science or they've used a life-sustaining treatment in the past, they would want to have that life-sustaining treatment provided again. But for most people, there is like an invisible line in the sand, a point where they would not want that treatment anymore. Providers need to educate regarding the good and the bad of each of the life-sustaining treatments, the functional level that is anticipated after receiving a life-sustaining treatment. So we need to be careful how we ask if the information we're providing is understood and assess what their comprehension is. And we don't say things like, what did I just say? Or do you understand me? We want to have a dialogue back and forth with that patient and make sure that what we're telling them, that they're hearing what we're trying to convey. And that's a difficult thing to do in a compassionate way sometimes. So factors that can affect the patient choices, there's a lot of different things. I want to go through this part of my talk with my learners because this is a group of psychiatric residents that I'm going to be working with. And I'm going to have them dialogue back and forth with me, and what you could do if you wanted to is put some comments below. But I'm just going to give a few of the things that I'm going to try to elicit from them. Spirituality versus religiosity, because those aren't the same. But those are definitely factors that can affect a person's belief system and their choices. The age and the gender. of the patient as well as the generation. So race, sex, upbringing, generation, sometimes their life experiences that they've been through on their own or with another family member, friend, or loved one. What are their beliefs? What are their fears? What about money, finances, insurance? Who's going to pay for these things? What's it going to do to my family? If they're the breadwinner, or if they're the one that is insured, or if they're the one that's receiving like Medicare benefits or a disability benefit check, money can certainly impact the entire family. And then if they're in the hospital for a prolonged period of time, that can certainly affect the family because hospitalizations can be extremely expensive. So all of these factors can affect a person's choices, as well as their education level, their level of understanding, their belief in their physician and their provider team, their social influences. What do they see on media? What have they encountered in movies and on YouTube? What do their friends believe? What does their family believe? What are their friends and family telling them? So all of those things I'm going to try to get elicited from my learners during this talk. It's going to be more interactive. I know I don't really have that interaction with you guys, but I'm just practicing with you, so thanks for that. Another thing I want to talk with the mental health learners about is existential suffering and what that statement can mean to them. Mental health professionals do deal with belief systems of people a lot more so than maybe the healthcare professionals do. Physicians, nurse practitioners, nurses, we can get into some of that, but we don't get the amount of training that our chaplain does. We don't get the amount of training that the social workers do. Those LCSWs, the licensed clinical social workers, get a tremendous amount of training and practice, as well as our mental health, our psychology experts, and our psychiatry experts. So what does existential suffering mean, and what circumstances might there be existential suffering? We want to assist in caring for these people and knowing what their background is that can cause barriers in either them accepting care at earlier points in their disease process, or the reluctance to now accept for comfort-focused care and possibly bring more harm to themselves and cause a more rapid decline by continuing to request aggressive care. Because sometimes some of these treatments, like chemo or different heart medications, can actually make people sicker, weaker, feel worse, and have a lower function, a lower quality of life. If you're tied down with a bunch of nebulizer treatments or taking steroids and you have an upset stomach because that's what helps you breathe or that's what you think you need to do, sometimes those things can actually make you feel worse rather than focusing on symptoms and letting go of some of those medications, whether it's a multivitamin that's giving you indigestion or it's a cholesterol medication. If the life expectancy is limited just to a few weeks or a few months, those medications we might be able to let go of, and it might actually improve the person's quality of life, but because of fears, that might be limiting for them. When facing that final chapter of life, patients deserve honest and accurate information. We have so much knowledge and such tremendous technology right now at our fingertips that we have to, as physicians, we have to responsibly inform patients and their loved ones of these options and those outcomes so that we can help guide them to the decisions that are going to be appropriate for them. The next thing I want to talk about in an interactive way with my learners has to do with the good and the not so good phrases that we can use with our patients. So I'm going to have them, give some different phrases that they have used or have heard that they think maybe are good or not so good. And I know we've talked about this in other videos, but I'm specifically going to go through these with mental health professionals because I think it's really important to get their aspect and their take on these things. We want to find a way that we can communicate with them. And some of the phrases that are not so good is when we use the word fighter. They are fighters. They have fought to get to this point, and to imply that gives them that burden that they feel like, I have to continue to fight. And so we're not really in a war. We are struggling. We want to live. That's a normal response for a person, but we don't want to add burden to them. So we like using the word courage because it does take courage to have a terminal disease or a serious illness and then to make difficult decisions. We don't want to use the word quit because none of these people are quitters. They are all brave, and they are bravely facing the information and listening to us and making those decisions that are necessary. There's no do nothing. We always have something that we can do. Their strength to accept the information that we're providing them and to courageously make those decisions, that strength inspires us to see when our patients are like, tell me what I'm up against because I really want to know the truth. If it's time for me to make decisions, I want to make those decisions. We don't want to put patients in a place where they feel like they have to at least try, because that implies that they're going to do nothing. And we are always trying, we are always working, and we are always doing something, but we're changing what we're hoping for. So we are hoping for symptom management. We want them to tell us because we want to learn. One of the things I'm going to encourage these learners to use is the phrase, tell me so I can understand. Let me better understand. Let me rephrase what I understand from you, and please correct me if I don't understand what you're trying to tell me. I want them to use the phrase, help me to know more. I would like to learn from you. Those are phrases that I think are good for these learners to use, and certainly the use of appropriate silence. Not silence so long that it's painful for both parties of the patient and the family and the physician or the mental health professional, but silence long enough so that we can allow those words to sink in, whether they're telling us or we're telling them, and then we can acknowledge the emotion, because we have emotions too, and these things can be upsetting for us. We don't want to mislead them and give them a glimmer of hope. That's not a good word that I like for health professionals to use. And I know a lot of patients are hoping for a miracle, but miracles come every day, but we may not get the miracle that we want. I also have had healthcare professionals tell me they don't like the phrase, it's going to be okay, because it's not going to be okay. This is difficult, and we don't know how you feel. A lot of us have been through this with other patients, or we've been through this with our own family members, but everybody's journey is a little bit different, and we need to respect that, and that's why we want to learn more. So those are some of the phrases that I want to get from my learners, and I want to have them go through this exercise and dialogue that. We want to talk with our patients about their fears and help them address those fears. So we're going to list a few of those fears, and we've already talked about a few of these, but a big fear is the fear of loss. They see their independence going away from them, their freedoms and liberties going away from them, because there's so many things that they're not able to do that they used to be able to do. It might be a job, it might be activities, and that takes away joy from them. So their loss of control removes joy from them. They're also seeing a loss of time. They see years dwindle to months, months dwindling to weeks, and then when they finally are beginning to count it, if I've only got 6 or 7 months, I only have maybe this many Saturdays or this many weekends, or I'm not going to see somebody's birthday or my own birthday again. I've already experienced, my last Thanksgiving. So these types of losses can be huge burdens because of that anticipated loss. Mortality itself, facing their own mortality. The thought of being dead for some people is not conceivable, and the process of thinking about the process of dying can be insurmountable for many. Changes in relationships. They've been the patriarch or the matriarch of the family. Maybe they've been a breadwinner, and now to become dependent on others and to need more assistance is not something that a lot of patients find acceptable. Communicating, being able to talk with someone about their illness, about their fears, about their concerns, about the process of dying, about being dead. Sometimes they have a friend that they can talk with some of these things about. Sometimes it's a family member, but there's generally not one person that can fulfill all of those roles. And so that's why it's necessary to have the mental health professionals help us support our patients they can feel isolated. And we want to address that isolation, that sense of being alone. We want to certainly address their physical symptoms, because sometimes their fear will include fears of pain, fear of suffering. Fear of shortness of breath is significant for a lot of patients. Fears about the regrets, things that I could have done, should have done, things I wish I hadn't have done. So we need to address those regrets. Many patients fear concern about their cognitive change. What am I going to be like? Am I going to say something silly? Am I going to do something silly? Am I going to make poor choices? And they fear that loss of control of their own cognition and their own mental capacity and capabilities. Realities: getting to the doctor, getting food, accomplishing their activities of daily living, being able to do their instrumental activities of daily living, whether it's using their cell phone, turning on the television with the remote. Any of those activities and loss of their ability to complete those activities can be a problem. We can also have concerns about the effects of the death of the patient on how that's going to affect our entire family. What is this going to do to my family? Will they fall apart? Will they argue? Will they come together? What are the concerns that they have on how this is going to affect others? And I see that so often, that even though the patient is the one who's facing the end of life and they're the ones with the symptoms suffering, they're still concerned about their family and what is happening with them, how it's affecting others. Needing to change their living space. That's a huge concern, a huge fear for many, because they want to be in their own home. And with the loss of activities of daily living, with the loss of their ability to be independent and needing more care, many of them are concerned they're going to have to go to a place. And many patients fear going to a nursing home. Many people don't want to be in a facility, and lots of people don't want to be in the hospital at the end of life. And that's a very difficult fear to face, because it happens for so many people. And we need to address that. We need to talk about that and what we can do to help them know there's always going to be a place for you, and you have given so much to so many for so long. Now it's our turn to give to you. We also want to address their fears about life-sustaining treatments, and that if they choose to not receive a life-sustaining treatment, whether that's blood products or artificial nutrition or dialysis or CPR, if they choose, I don't want to ever be put on a ventilator, that we're still going to care for them. That electing to not receive that, you're still going to get full support. You're still going to get full care. You just, at the end of life, when your life comes to an end, we will support you through that natural dying process, and you won't have that life-sustaining treatment administered. Because sometimes you get that life-sustaining treatment, and what you're brought back to is a very short lifespan where you may be fully dependent on some of those machines. And for some people, that's being kept alive, that's not living. So we want to address the fears and questions about life-sustaining treatments when they're used, when they're administered to a person, and how that affects their independence, how that might make them dependent, and what it might look like if they choose not to receive those things. So those are some of the fears, some of the more common fears. Certainly there are many fears that people have, but those are some of the more common ones. Then we're going to have an exercise with these mental health learners to talk about some of the difficult questions and answers that people have, and providing that importance of communication. So we want to ensure that the people that we're taking care of have all of these questions addressed, and that we're able to communicate in an open and an honest way. So we need many disciplines to help address the body, spirit, and the mind. And this exercise that we're going through is all about with our mental health professionals to help us gently learn from our patients, to assist our patients finding their goals of care when their prognosis is poor, the trajectory is guarded, and their time is short. We want to help guide their journey through their health, life, and their illness as death approaches. When there's such a thing as a bad death, there must be such a thing as not such a bad death. I'm not so sure that there's a good death, but I know that there are bad deaths. And we want to find out what the patient believes about what a bad death is and what a better death might be like. So likely, these patients have never considered that. I mean, I do encounter some patients who've considered it. Maybe they've been through a death experience with a family member that left a mark on them or on their heart, and they don't want that kind of dying experience for themselves or for their loved ones to witness. So that's really important concept for us to try to gather, and that's where we really need that mental health support when we approach these patients and talk with them. We want to provide comfort and compassion to those who are in need, and that's not just the patient, but that's their family members as well, because they're part of that patient world, and we have to be able to support their needs. Physicians are the expert medical guides, and physicians, mental health, spiritual health, all of this needs to be addressed as a person's life expectancy becomes limited. So at the very end of this process, we're going to break up into smaller groups, and we're going to discuss some of these things, and we're going to give some good examples and some bad examples. So thanks for listening and being with me today and helping me practice for this education piece that I'm going to be doing with psychiatry students and learners here in just a couple of weeks. So thank you all very much. I appreciate you being here today. If you've got any suggestions that I might use with these learners, please drop it in a comment box below, because I do want to provide them the best education and the best learning experience that I possibly can so that they can help meet the needs of their patients. Bye now.